Dr. Rao, which, he's Sunil, I call it, but that very young, but has accomplished a lot. He's associate professor of medicine, Duke University Medical Center, working with the DCRI. Has made a great name and actually has pushed the field of interventional cardiology with a radial intervention. So anytime you hear the radial about in the United States, is Sunil is a lead discussant, and of course a lot of strategy in terms of how to reduce bleeding, bringing the bleeding to the really or the top most point has been credited to Sunil. So Sunil, come here and give us a little input on improving the safety of PCI.
Can I just say
Yes,
one
Roxana?
thing about Sunil? First of all, I'm proud to say that he is professor of medicine at Duke University. As of November 1st. I know there's a lot of things happening, but that one I want to say, and it's so well deserving. And without you, I don't think we would have come to where we are today, because you were bold and tough on the bleeding aspects. And because of you, we're all, I have a career now because of you, thank you, but also because you were bold in really attacking that important problem. And now it's front and center. And just today, Nitin Barman, who's here, I don't know where he is, but he said, I think the best thing to do is just assess everyone's bleeding risk first before we think about how we plan our strategy, and that's thanks to you. So thank you for being here.
Wow, that's really nice. Thanks, Roxanne. I met Dr. Moran actually at the FDA when I was a fellow. We actually had a think tank about it, and we talked briefly about bleeding, and I think she was the first person who actually, besides Bob Harrington, who thought there might be something to explore here in this particular field. It's thrilling for me to come back to New York City. I'm a country doctor. I live in Chapel Hill, North Carolina, so I was actually born in New York City, but I don't get to get up here very often. And it's really humbling to present in front of this crowd. I will say one thing, though. I think that LaGuardia would work a lot better if Dr. Sharma and Dr. Kinney ran the place. I will just say that briefly. And I've gotten over the Yankees win over the Indians, by the way. I'll get that. So I want to talk to you about this bleeding story that we got interested in when I was a fellow. And I'm going to talk to you about sort of my experience and how I got interested in this particular area. And I was an intern at Duke in 1996. And I did 2 months of cardiology. I was the only intern to do 2 months. Everyone else did 1 month. And it was extremely busy, just I'm sure like it is here. And so for the interns, it was a lot of work. And you have to think about where we were in 1996. You had to justify putting stents in. You had to say, we got a big dissection with a balloon, and that's why we put a stent in. People were terrified of the stents closing. So patients were getting the kitchen sink thrown at them. Aspirin, ticlopidine, warfarin, dextran. Patients were getting a lot of antithrombotic agents to prevent stent closure or stent thrombosis. And the folks who were on the receiving end of the downside of those strategies were the interns. And every night around midnight, you would get a call that would say, patients in room X, Y, and Z all just threw up blood. And so you'd run there, and I just kept thinking to myself, this can't be a good thing to have patients having this kind of bleeding complication. And I remember as I became a fellow in '99, strategies have become much more refined. Now we had 2B3 inhibitors. It was the golden era of 2B3 inhibitors. Dr. Moliterno was involved intimately in many of those trials, as were Dr. Moran and the folks at CRF and people here at balloon pumps, patients who were getting primary PCI and shock. And I remember it was one particular case that actually got me thinking about how to think about the safety of PCI. It was a patient who came in. Durham, North Carolina, for those of you who don't know, has a big blues festival every year. It's one of the most famous blues festivals. And when Muddy Waters was alive, he would go there. Howlin' Wolf, when he was alive, would go to Durham. And there was a patient who was native to Durham who came into the hospital with an acute MI. The ambulance actually got called to the blues festival. He went to the cath lab. This is just a representative angiogram. It's not his. Of an LAD occlusion, got it opened, got a stent put in, got 2B3 inhibitor, and he was admitted to the CCU. So I was talking with him, and in the middle of our conversation, he stopped talking and slumped over. And he ended up having a softball-sized intracranial hemorrhage and ended up dying. So that's what really got us interested, saying, there must be a balance that we have to strike between ischemia and bleeding, and how do we find that balance? Well, first of all, we have to convince the community that bleeding is something that we need to try and avoid. At the time, the mindset was it doesn't matter if the patient bleeds as long as they don't have stent thrombosis or recurrent MI. Remember, the old adage was you can always transfuse blood, but you can't transfuse myocardium. So let me talk to you about a case. This is an 81-year-old female who came into the hospital with a non-STEMI, sort of classic of what you see at your practice. 5 French, right femoral approach, 90% type A lesion, gets a stent, no post-procedure CK-MB elevation, but does have a hematoma. This is, by all measures, a successful case. The patient didn't die, they didn't have a periprocedural MI, but they did have a bleeding complication. Unfortunately, because of this patient's risk factors, CKD, diabetes, older age, she developed a necrotizing groin infection and unfortunately ended up dying 7 days later. Okay, so what about another case? This is even more recent. Okay, 58 years old. It's a very young patient who underwent 2 vessel stenting for acute coronary syndrome 5 weeks prior. Gets treated with, aspirin and clopidogrel. One could argue he should have gotten a more potent P2Y12 inhibitor. No one bothered to ask him about his bleeding risk. Developed upper GI bleeding, aspirin and clopidogrel stopped. Both of his stents, he has double vessel stent thrombosis and presents with STEMI and shock. So these are 2 cases where the initial procedure was successful, but the patient had ischemic events precipitated by a bleeding complication. So over the next few minutes, this is what I'm going to talk about. And we'll talk about a lot of data that has been generated in this field over the last 17 years or so. Remember, what we're trying to avoid is ischemic complications. So we are, by necessity, using potent antithrombotic agents. When we blow the balloon up in the cath lab, we're causing iatrogenic plaque rupture, which leads to a cascade of events like thrombin generation, platelet activation. And so our strategies are aimed at these particular pathophysiological events. If you look at the complications in the NCDR action registry, these are patients with ST elevation MI or non-ST elevation MI. We are victims of our own success. The overall death rate in STEMI patients is 6%. The overall in-hospital death rate with non-STEMI is about 3.4%. I encourage many of you who are in fellowship to go back and look at the mortality rates in the ISIS-2 trial. 15%. Right? So this has been cut dramatically over time. So the most common complication these patients experience is major bleeding. And in the NCDR registry, you have to have a major bleed. I mean, this is like a big-time bleed, a 4-gram drop in hemoglobin, a transfusion. These are not hematomas. These are big bleeds. And this is what patients remember. And the sites of bleeding, as you know, can be either systemic or at the access site. Most patients undergo an invasive risk stratification, so depending on the presentation of the patient will have more access site bleeding or less. We looked at this in the NCDR. We looked at this. These are representative studies at the DCRI. These are randomized trials showing that there's a relationship between the acuity of the patient presentation, the proportion of patients who will develop a bleeding complication, and the proportion that's related to the access site. So a patient with stable angina, for example, the vast majority of their bleeding is related to the vascular access site, but their bleeding rate is very low. It's like 2%. So, I mean, it's actually impossible to kill these patients. They tend to be younger. They present pretty stable. They have type A lesions. The non-STEMI patients, on the other hand, have a bleeding rate overall about 6%. But the vast majority is non-access site related. Why? Because not every non-STEMI patient gets a PCI. Some patients will get bypass surgery. Other patients will get medical therapy. In the STEMI patients, they have the highest bleeding risk, 12% in the NCDR. So 12% of patients will have a bleeding event. And the majority of those bleeding events are related to the vascular access site. The reason this becomes important is because if you have a vascular access site strategy, it's going to have the greatest benefit in the STEMI patient. And as I'll show you, that's exactly what we've seen in the Radial Approach studies. Bleeding is obviously important. This is just one representative study. Dr. Moran has published numerous papers on this showing that regardless of how you define bleeding, there's a stepwise increase in the risk of 30-day and 6-month mortality as bleeding severity worsens. This is a very blunt way of looking at this way back in 2005. We just wanted to know whether patients lived or died. And certainly it shouldn't surprise you if a patient who has severe bleeding, that's intracranial hemorrhage or hemodynamic compromise, if they die. I mean, that's not surprising. What is surprising is the fact that even patients with mild bleeding seem to have about a 60 to 70% increase after adjustment relationship with 30-day mortality. This is just a brand new paper that Dr. Moran just published with her group. It came out, I think, 2 weeks ago, looking at outpatient bleeding, an area that we actually don't know a lot about, primarily because we don't capture it in many of the registries, showing that shorter duration of treatment with aspirin and clopidogrel is associated with fewer bleeding-related deaths. And this is a way of looking at direct relationships. These are still associations at the end of the day, but there's a reason why these patients tend to have higher mortality. And the way to think about it is, again, I'm a knuckle-drugging cardiologist. I don't like to make things complicated. What do we do when a patient has recurrent ischemia? We intensify therapy. What do you do when a patient bleeds? You got to stop therapy. There's nothing else you can do. And that is probably one of the ways that is the underlying mechanism between the relationship between bleeding and mortality. We also looked at what happens to these patients long term. Using the NCDR cath PCI registry, 461,000 patients over the age of 65, very high risk bleeding group. Patients who tend to bleed and survive tend to have recurrent bleeding. So it's not just about the mortality or the MACE. It's also about the fact that these patients continue to have bleeding risk even over 30 months of therapy. And that's why it's really important to delineate which patients are candidates for long-term therapy and which ones aren't. And we'll talk a little bit about that. Here's a patient, here's an analysis from Horizons MI, again, very, very recent paper, showing how time from the index presentation with STEMI modulates the relationship between ischemia and bleeding. So early on in the acute period, the ischemic and bleeding risk is about the same. In the subacute period, the ischemic risk outweighs the bleeding risk. We know this, right? The highest risk period for a patient with an MI is the first 48 hours. That's when the risk for recurrent MI, stent thrombosis is the highest, and then it precipitously drops off. Whereas if you look at the late period, the late period, the ischemic risk, again, outweighs the bleeding risk. So this is another way of thinking about how we should treat patients long-term with antithrombotic strategies, which will become an even more acute problem as we start talking about how to incorporate oral anticoagulants into our strategy. Dr. Sharma presented the COMPASS trial data.
But in this one, I saw it just came out yesterday.
Yeah.
But is that true? Because I thought we have been saying the late is more bleeding than ischemia. But
right.
With this central graph, it makes it that ischemia is more important in the late time.
The important thing I think is here, remember you select out the bleeding patients. The patients who are going to bleed early. And then what you end up with is a population where they probably have higher ischemic risk at the end.
And the way this was done is that you do get rid of them because you couldn't count them again once they, the patients with recurrent events can't just keep it.
Right.
That was why it took so long to do this paper, because we had to really do a lot of work in understanding patients with recurrent events. But here it's showing that the ischemia is still important, but look at the bleeding is also very important as well. But these are all STEMI patients. Remember that too. I think that's the other.
So what you end up doing is selecting out the patients who bleed in hospital.
Right.
What about costs? So, we've been talking about costs in healthcare for I don't know how long. But now I think it's actually becoming an acute problem. On a monthly basis, in fact, I just got it yesterday when I was on the plane, is a list of what my cath lab costs are relative to my peers in the Duke cath lab. And all of us get upset about it because it's not risk adjusted. Let me just say that Magnus Oman is a very, very expensive doctor, okay? But then he's also doing a lot of the shock patients, right? So it is driven to some extent by that. And certainly bleeding complications are associated with increased hospital costs. There are two ways to look at this. You can look at it per event or patient. Okay? And we looked at it both ways in this particular paper, where each moderate or severe bleed was associated with an increase in hospital costs of about $3,300. The per patient cost is about $530. Transfusion certainly doesn't reduce costs. Each transfusion event is associated with an increase of $2,000, and a per patient cost is $287. This is driven primarily by length of stay. Patients who bleed in the hospital have longer length of stay, have longer ICU stay. So this is the world that we created, I think, where if you start thinking about how we treat patients with ACS or PCI, you can't just focus on the ischemia. Because if you just focus on one, you're really just treating half of the patient. Okay? So how do we reduce this risk? Well, we have to think about the mechanisms. The number one thing we have to acknowledge is that there is confounding, right? Sick people bleed and sick people die. You have to be careful about that. But patients do have bleeding risks, and we know this when we follow patients long term. Certainly severe bleeding, the mechanism is hypotension or frank shock. That's unusual. I mean, we don't see intracranial hemorrhage anymore these days that much because we're not using 2B3 inhibitors routinely. The real issue is mild or moderate bleeding. I could do a whole talk and actually talk all day about blood transfusion. We're doing an NIH-funded trial now called MINT, where we're randomizing ACS patients to do different transfusion thresholds. But the big mechanism really is cessation of antithrombotic therapy. And so how do we do that? Well, first of all, we should identify who's at risk, and we have tools to do this now. And I think, your comment is right on. We should be probably doing this in every patient. But I will say that to go back to Dr. Moliterno's talk, big data should be doing this for us. Okay? Eventually, the EHR will catch up to the point where it will calculate this automatically. We can't have one more thing to do as clinicians, because then we'll never do it. There are dosing strategies. Make sure you don't overdose your patients. Vascular access. So if you're going to do femoral arteriotomy, use best practices. Ultrasound, fluoroscopy guidance. Don't just keep sticking until you get a gusher. And then, of course, my interest has been in radial access. We won't talk much about blood transfusion because, again, I'd keep you here all day if we did that. So who's at risk for bleeding? This reference is dated on all of you, I'm sure. This is the old "Where's the Beef" commercial from Wendy's. But this is how I remember who's at risk for bleeding. It's generally the little old lady, right? Who are consistently predictors of bleeding are older age, anemia, low body weight. We don't get a lot of low body weight in North Carolina, but it is a risk factor. Poor renal function, shock, and emergency procedures. There is an app that's available. This is free download. We developed this through the quality committee of SCAI using the validated Blue Cross Blue Shield model, which uses random forest models. And it will simultaneously give you the risk for the patient's acute kidney injury, transfusion, and death. It's very easy to use. I encourage you to use it. You can actually print this out if you'd like and give it to the patient as well. The other big development, and I think this is something that Dr. Moran and I have been chasing for a long time, is how do you differentiate patients at risk for bleeding versus ischemia? Because if you think about who's at risk for ischemia, it's older age, females, chronic kidney disease, the same stuff. But the DAPT trial was large enough to try and make an attempt at differentiating who's at risk for bleeding versus ischemia with long-term dual antiplatelet therapy. So this is long-term outpatient bleeding. This is a risk score. ACC has an app for this. You can actually download this, and you can figure out which patient is at risk for long-term ischemia and should get long-term DAPT, and which patient is at higher risk for bleeding and should really have shorter DAPT. There are a couple of caveats with this. PAD, for example, is excluded from this DAPT score. That's a big driver of bleeding, obviously. And remember, these are patients who already successfully had 1 year of therapy without a bleeding event. So just keep those things in mind. But this, I think, is a step forward in trying to differentiate which patients should be treated long-term with DAPT after PCI. What about radial access? Remember, the patients with STEMI at highest risk for bleeding, high risk for vascular access site issues, this is where we see the benefit. This is a meta-analysis done by Giuseppe Ando and Davide Capodanno. 4 trials, 17,000 patients randomized to radial versus femoral, showing that radial access reduces major bleeding, reduces mortality in STEMI. 17,000 patients, 4 trials, still not a Class 1 recommendation by the American guidelines. I don't know why. The European guidelines have been very prescriptive. They've actually said that radial access is preferred in ACS patients, because I think the data do support that. We talked a little bit about costs. I'm going to talk briefly about how radial access influences costs. Again, by reducing bleeding, you reduce length of stay. You save about a half a day in the hospital. That translates into about $1,700 saved per procedure. Now, costs mean different things to different people, right? So cost to the patient is, what am I paying at the pharmacy for this drug? Cost to the health system or cost to the society is what we as a society have decided to pay in taxes to help support healthcare. So Medicare, for example. What's interesting about this study is, what is the hospital expending to take care of patients? So this is direct hospital costs. So your hospital potentially could save up to $1,700 per patient by adopting a radial access approach. This is primarily driven by same-day discharge. Dr. Sharma and his group was one of the first people to talk about same-day discharge with a femoral approach and vascular closure. So certainly you don't have to do radial to do same-day discharge, but it does help. What's been the growth of radial? When we first looked at this in 2008, we looked at data from the NCDR between 2004 and 2007. 600,000 procedures at that time. The rate of radial approach in the U.S. was 1%. You can see the growth in radial access by this paper that Dimitri Feldman did in 2013. According to the latest data, first quarter of 2017, 36% of all PCIs in the U.S. are performed via radial access. Our goal in the radial community has always been 50%, so that we don't lose our skills in femoral access, which all of you will need when you start doing structural procedures. Eventually, maybe we'll put a valve in by the radial. I hope I live that long.
Right now we are done. Our goal is 33%. We are around 24, 25. We started low, but with Barman and some few other people more dedicated. So we have made a threshold of 33. We are not reached 33 yet. We are about 27, 26, 27.
What's interesting about using radial access is we looked at what does it take to actually impact your hospital level bleeding rates? One of the things that we've noticed is that hospitals that tend to use less than 20% radial, for example, or 15% radial, tend to use it in the lowest risk patients, the 40-year-old executive with normal coronaries. You're not going to have an impact. That's the so-called risk treatment paradox. The patients at highest risk are not getting the best strategies to make them safe. So what we looked at was, how does this affect your bleeding level, or your bleeding at the hospital level? And we found that you have to use some kind of bleeding avoidance strategy, bivalirudin, radial access, in at least 85% of your patients in order to have an impact, because that's what makes you overcome that risk treatment paradox. If you're using those kinds of things routinely, you're going to use it in the high-risk patients because that's part of the protocol that you have. This is what's happened in the United Kingdom. In the United Kingdom, this is radial adoption between 2005 and 2012. I'll tell you something very interesting in the UK. In 2014, the largest private insurer in the United Kingdom increased physician reimbursement if you did radial access and sent the patient home the same day. Per patient, you make 300 pounds more. So it's an interesting way of incentivizing safe procedures. They actually ended up with calculating about 454 lives saved over 8 years by changing practice from femoral approach to radial approach, all because of STEMI patients getting radial access. This is not elective patients that drives this. It's the STEMI patients. So let's put this together. This is a patient that we did a couple of years ago, a 79-year-old Laotian female presented with non-STEMI. She spoke a dialect of Laotian that our translator didn't speak. So we had to communicate with her through her daughter, who lived in Greensboro. Very sophisticated family. Dr. Moran, you will be impressed to know that the first thing they did was they printed out your article on bleeding risk and handed it to me when I went to consent them. Talk about high-risk angioplasty. This patient had very complex distal left main disease. They refused cabbage on cultural grounds. Patient was unable to be weaned off of IV nitro, so she was referred for high-risk PCI. You can see the bleeding risk here, very, very high risk. This is a sheathless 7 French system via the left radial approach. She was a short female, left radial, left subclavian tortuosity. You can see the very, very complex disease there. We did this with hemodynamic support. Her EF was down, and you can see the final result here with a culotte approach. We use unfractionated heparin because of her renal function. Aspirin, clopidogrel, she was not a candidate for prasugrel. We didn't have ticagrelor yet. She was discharged on a PPI and did very, very well. Yeah, for a balloon pump. For a balloon pump, yeah, absolutely. So let me summarize this. I think ischemic outcomes have improved over time, so bleeding has become an important event that we need to try and reduce. The mechanisms are varied. It's likely driven by cessation of antithrombotic therapy, maybe the blood transfusion. Stay tuned for the MINT trial approach. So reducing bleeding risk and while inhibiting thrombosis is a clinical priority. The way you do that is assess bleeding risk using available tools, dose your drugs appropriately, use radial access when it's appropriate. Again, thank you very much for the invitation. It's a real honor to be here for the 100th live case presentation.
Thanks so much. That was a great talk. Thanks for coming.
Yeah.
I'm wondering if you can comment on a couple of things. One is, as pertains to radial access, the radiation exposure.
Yeah.
And some of the contrast use, but also the neuromotor effects that we see or have been reported with radial.
Yeah. So those are great questions. So there's no question that we did a nice meta-analysis that was published in Lancet around the radiation exposure issue. There is higher radiation exposure with radial approach compared with femoral approach. There's a study that's being presented at TCT this year, in 2 weeks, I guess, where they used the RADPAD. It's a randomized trial to look at how much of an impact it has on radiation exposure. I won't tell you the results they've submitted for publication. I think you'll find that very interesting. The overall incremental increase in radiation is actually quite small, but over a lifetime can accumulate. So one of the things that SCAI is really encouraging people to do as they adopt radial access is to use as low as reasonably achievable rates. That doesn't just mean using the shielding. And one of the things that I think we should have talked about this morning is with orbital atherectomy, for example, where you have to go so slowly, compared with rotoblator, you get more radiation exposure. So use 7.5 frames, for example, for fluoro. So I think there are ways to reduce that risk, and potentially RADPAD could be one of them. Now let's talk about the hand function issue, because this is something that comes up periodically. There's a really excellent study out of the Netherlands that's been published in JACC Interventions looking at what happens to hand function between radial and femoral access as a randomized study. It turns out that there's no difference. And the reason is that in that trial, patients who got randomized to femoral reported hand complaints. So I don't know how to explain that. And certainly with hand grip testing and even with capillary lactate levels in the fingers, there's been absolutely no difference, even when the Allen's test is abnormal. And we actually have a presentation specifically about that at TCT on Monday afternoon if you're there. I'm sure the slides will be archived. But I think that's probably something that anecdotally occurs, but really the data have not borne that out.
Let us maybe know about the anti-radial campaign of Mount Sinai Cath Lab. Tell us the background of it. Why you would not do the radial? Yeah.
When you have a highway and you can go 120 miles an hour, why are you taking a small road and going through all these curvy bends and taking longer time? Now, there's a learning curve for this. Number two, I can always also vouch is that one hand function is not. I think unless you have a prospective randomized trial of having a patient having both procedure and then ask the patient what they want. I can tell you when patient, if you ask a patient who has an important job using hand, they will tell, don't touch my hand.
Yeah, I think those are great points.
With my leg.
So we actually have two large randomized studies, Rival and Safe PCI for Women, that Dr. Moran was involved with, where we did ask patients that, and they preferred radial approach. But I agree with you. I mean, it's not 100% preference, right? And we've certainly... Yeah, so that's what we asked. Yeah, so we looked at patients who had had prior procedures via femoral access. But I agree with you. I mean, the number one contraindication doing radial is the patient doesn't want it, right? And the number one risk of doing a radial procedure is a non-diagnostic angiogram. So what we see periodically is patients or operators who will persist in radial access and just get shitty pictures. Then you haven't done anybody a favor. Yeah.
All of them are aeograms. I tell them,
Right.
10 aeograms.
Yeah. So if you're going to do it, you really got to get good at it and learn how to do it.
Yeah, he's the radial guru of Cath Lab.
I would bring up one point on the patient side. I just wonder if patients were making truly informed decisions. We know there's insight levels and the amount of time we spend in the consenting process. If a truly informed consent was provided for these access differences, I wonder, if those same patients would still argue for the ones that do argue for femoral replacement. My question is more related to the something that you brought up in the line case with respect to how we practice in America and the large denominator of operators and a low volume. Do you think it's really practically believable that we can achieve the type of change you saw in the UK? I mean, we look at other paradigm shifting treatments that had significant absolute reductions in mortality, whether it was TNK versus streptokinase or primary PCI versus lytics or door-to-balloon times. They were adopted in a matter of years. I mean, I wasn't around during all those times, but just looking at the utilization rates. Whereas here, I'm always perplexed. Obviously, the guidelines play into that a little bit, which doesn't make a lot of sense, and hopefully that'll change. But even beyond that, I think the backbone of the qualifying phrases of experienced operators and experienced centers, it feels to me like that's more of an excuse to not transition practice. Do you think it's really realistic to believe that we can achieve 90%?
So that's a great question. With respect to your informed consent issues, maybe I'll leave that to your discussion during faculty meeting that you all can have that. But I've been continually surprised to see the uptick. I mean, honestly, maybe I'm a little cynical, but every time I see the NCDR report, I'm always, it is higher this year. I mean, I thought it was going to top out at 20%, honestly. I think the real change is going to occur with the people in this room. I mean, it's the trainees that are going to come out who are well-trained in radial. I mean, most of us picked it up after the fact, and it's harder to do it that way because at the end of the day, you're talking to a patient and you're sort of saying, look, we're going to try this radial access. It may or may not work, or we may have to switch over to femoral. And, thank God for patients who will let us do that. So it's really the trainees that are going to change that. And I think as we get an infusion of new interventionalists into practice, that's what's going to drive that number. Are we going to be 90%? I doubt it. That's a big motivator too, yeah. So no one's getting any thinner.
Patients will always be. Other question could be tied with the reimbursement. What if the radial gets $150 more for the physician?
Right.
Knowing that you are
Cath lab
saving
directors
institution,
will
every
change.
study has shown radial procedure saves money to the institution.
Yeah.
So insurance companies
That
put
money will go to get a massage chair.
So we actually had that conversation with CMS about a year and a half ago, and we had a very, very nice and insightful CMS administrator who, off the record, said, so let me get this straight. You have a strategy that patients like and saves money, and you want us to pay you more for it? And unfortunately, that's not the way we pay for things in the United States. We pay for things based on effort. And so in a funny way, as a radio community, we have to make the opposite argument, that it's actually not easy to do. It takes a lot of time, and it's a lot of effort, but that's what we'll get paid more. So it's a kind of a funny system.
It's really true.
And more radiation also, I mean, there are certain factors here to consider. Number one, the radial is intuitive, because if you use a small axis, you will save groin bleeding.
Yeah.
There's no mystery about that.
Right, it's almost a straw man argument, right?
Particularly if you go and give it a trial in areas, for example, that at the time these trials were being done, there were several systematic limitations. Not all of them had a femoral angiogram, for example. So I get an impression that the trials are made to prove radial. So that's a flavor of bias. And the other aspect is many of these trials failed in the primary endpoint. There was no difference. Right. All those bleedings, this and that, was conveniently saved.
Well, that's one trial. Rival. That's the only trial that was negative. Yeah.
Well,
Matrix was positive.
But interestingly, it was quoted even in this lecture as one of the key trials. But the primary endpoint was negative. The secondary endpoint, which was the intuitive endpoint, was a major bleeding. So the trials were somehow a little bit created. I think the debate was created a little bit by the trials. Because you go down to say, you know what, we're going to try something, and we're not going to do femoral angiograms, and we're going to focus on the secondary endpoint. And then everybody says, okay, this isn't that what we're all talking about.
He's a femoral, you get it?
I would agree. I think we have to agree to disagree, because only one
this is the
trial.
challenge that Sharma has.
Just with all due respect, I mean, people asked us to do the trials. We did the trials. 19,000 patients. Matrix, primary endpoint, better with radial.
Exactly.
So I agree with you. I think we have to have best femoral practices, and that's a real issue. I mean, I personally, I don't do a lot of femoral cases, but when I do, I use ultrasound, and I didn't grow up with ultrasound. So I think, that's something that we definitely have to do. But I do take an issue with saying that the randomized trials have been biased. I think that,
so far, Matrix just came the last one.
Yeah,
so
but
the debate has been ongoing on for various other trials.
Yeah.
That their most primary endpoints were actually on the negative side, more so than the clear.
But I would argue that this is one of the areas where we have more randomized trials than probably anything else in cardiology. And so, I think we have to be a little bit careful about discounting randomized trial data.
So quick question. We focused on the procedure, but tell me, what do you think is an acceptable rate or target rate for vessel closure, long-term radial closure, and what techniques do you use to try to minimize that?
Yeah, it's a great question. So if you look at it depends on how you define it, right? There was a study out of Germany that looked at hand pain and said that's radial artery occlusion. So clearly that's not radial artery occlusion. So in that study, the radial artery occlusion rate was 30%. But when you actually use ultrasound or Doppler, the rate's probably around 10 to 15%. And then 50% of them will recanalize at 30 days. So radial artery preservation is a big deal. I mean, that's important. I think there are, the three big strategies are minimizing radial artery trauma. So try to use the appropriate profile of catheters for the case that you're doing and don't overstretch the radial. So if you have a small radial artery and you want to use 7 or 8 French, that's not a great case for radial, right? That's a case that you want to probably do femoral. Adequate anticoagulation. So, weight-based heparin. There's a nice study looking at the relationship between ACT and radial artery occlusion. You've got to be above 200. And then there's something called non-occlusive hemostasis, so making sure that you get enough hemostasis but antegrade flow in the radial. There's a very nice study looking at ulnar compression. There's a randomized trial of actually simultaneous ulnar compression with radial compression. And that showed a dramatic reduction in radial artery occlusion rates. So we measure our radial artery occlusion rates monthly, and our rate in our practice is around 0.8%. And that's because we track it, we have nurses who are educated in preventing it, and we do use ulnar compression if there's any issues around suspicious radial artery occlusion rates.
How do you track it? Every patient gets a radial, gets a follow-up ultrasound?
Well, so what we do is at the time of discharge, we do what's called a reverse barbeau test. Sure. That's how we track it. So if the patient has radial artery occlusion at the time of discharge, we'll do ulnar compression for an hour before they go home. So.
That's good.
Interesting. What do you think? There was a study published with the use of nitro right before you take the sheath out, like in the very end
of the procedure.
There's been a little bit of a mixed receipt of the trial.
So, we've done that routinely ever since we started doing radial, because verapamil comes in 5 milligram vials. So we give 2.5 of verapamil when the sheath goes in, and 2.5 before you pull the sheath. That randomized trial is very clever, actually, because they use nitro, which in a way preserves the blinding for the patient.
Yeah.
Because it doesn't burn as much as verapamil. So if you're giving saline versus verapamil, patients are going to know which one they're getting. So they use nitroglycerin, and it is a randomized study, and they showed that, again, the use of a vasodilator before you remove the sheath reduced radial artery occlusion versus not giving it. So we've been doing that. I mean, that was part of our practice anyway. It was nice to see some validation, I guess, of that.
So for the stage interventions, like this morning I did one, patient in love with the radial, I went in the same arm, no problems.
Right, so yeah, if you look at it, so the group in Quebec City has published on this, and every time you stick the same radial, the risk of radial artery occlusion goes up 5%. And that's sort of in the population of patients. So it's probably different based on the individual. Some individuals have big radial arteries. Some have smaller ones. You're probably not going to be able to stick that one repeatedly.
So would you recommend to change the arm for a stage? Or?
We ask the patients, generally we're staging after 30 days, so by that point they don't have any issues with sticking it again.
It's a more practical question of how you approach with the knowledge of size impacting RAO. Do you, across the board for diagnostic angiograms, use a 5 French cylinder and then upsize, or do you look at some pre-test evaluation of the probability?
I wish we were that sophisticated. We're not. We use 6 French slender for everybody, and then one of my colleagues likes to use 6 French diagnostics. I like to use 5 French. I think it's a matter of preference. And then the vast majority of our interventions are done using 6 French. If we want to use 7, we either go sheathless or use a 7 slender.
Now, to see the real benefit, you need to go high, 75% or 8.
Yeah, and I think that's just because you want to do the high-risk patients, yeah.
I'm talking about implementation in the lab.
Right.
This is something that is very important for me as director, because I know that in order to really see the benefit, 75% of my PCI has to be radial.
Yeah.
So staying in the 30, 40, 50%, it's encouraging, but we're not doing much. Is that a correct statement?
So I think, I think we have to be just a little bit careful about that. I think that's a general recommendation. My guess is that, Sinai is the premier lab in the country, and my guess is that if we were to survey your bleeding complications, it'd be probably close to 0. And that's because you get really good femoral access. You're doing complex cases to begin with, so you've got to risk adjust for that. So for a place like this that's doing a lot of volume, the benefit is going to be harder to see. You may see a benefit in terms of patient preference. Now, for a sort of lower volume lab where they're probably not getting good femoral access, that's where I think you're really going to have an impact. I think the general recommendation to incorporate radial into your practice is an important one. But we have to guard against sort of indicting operators who feel comfortable with femoral as long as they're tracking their bleeding rates, as long as they're using best practices for femoral. At the end of the day, it's really about getting good outcomes, not about one versus the other, I think.
And actually, for the New York State reporting, any pseudoaneurysm requiring thrombin injection is put into the vascular complication.
Yeah.
Just thrombin injection. So with that, note every other aspect of the individual complication. Mortality, Mount Sinai, less than 1/3 of the state. MI, reocclusion is like less than 1/10. Stroke, 1/3. Renal, the CIN, like 20% was reported. Only one area where we lose to state is the vascular complication. So it's sometimes is actually 30-40% higher. And that happened because of our radial use was 15-18%. Now it has gone to 26 to 27%, which we are tracking with the getting to 33% our target. Whether will that change, the only outlier I would say, the Mount Sinai has been in the state point of view. I think it does happen too, no matter how good we say, but vascular complications, knowing that we are the predominantly still a femoral lab, we lose compared to the state.
It's good that you know it. A lot of labs don't even know what their rates are.
All right, any other question? Sunil? Okay.
Thank you.
That's from there. Beautiful.